neurology, ophthalmology, cavernous sinus syndrome, along with intranuclear ophthalmoplegia. All right, so this is the last video for all of our pathologies. I know the eye is really annoying, but thankfully it's not too high yield. So don't get too bogged down if you get a little bit confused. What I really think the highest yield things are for the eyes are going to be your cranial nerve deficits and palsies, like cranial nerve 3, 4, and 6, specifically cranial nerve 3. Your LR6, SO4 should be very helpful for you. And then the last thing probably is the highest yield thing is like glaucoma. All right. The retinas, they do talk about it quite a bit, like the retinal disorders, but honestly on the exams, they're not as high yield as everything else. So don't worry too much if you're kind of confused with everything. Just take everything with a grain of salt that it's not as high yield as everything else. Okay. So next is just the cavernous sinus syndrome. So I want you to take a look at a diagram of the cavernous sinus when I'm talking about this, because it makes so much sense when something occurs. Okay. So cavernous sinus syndrome is just essentially a collection. So the cavernous sinus is a collection of all the venous sinuses on the either side of the pituitary. You're going to get blood from like the eyes and from like the cortex, and it's going to drain into the cavernous sinus, and it's all going to drain at the end into the internal jugular vein. So all of the blood from the brain, essentially, it's going to all drain into the internal jugular vein, and it's located within the cavernous sinus. Okay. So now the internal jugular, that means, is going to be the center of our issues. Okay, so let's say we have an expanding aneurysm in the cavernous sinus, okay, and that can lead to cavernous sinus syndrome. So cavernous sinus syndrome just means that there's compression within or increased pressure within the cavernous sinus. Okay, so that's what's going on. Now, it could be a mass, it could be anything, right? But let's say that, I'll give you an example. You have an expanding aneurysm in the cavernous sinus located at the internal carotid artery. So the internal carotid artery now has an expanding aneurysm. This is their favorite way of testing cavernous sinus. So take a look at where the internal carotid artery is within the cavernous sinus, okay? Because there's going to be two separate ones that kind of travel next to one another. There's going to be one within the cavernous sinus. That's the one I want you to look at. And I want you to look at it and realize how close it is to the cranial nerves, all right? And it's specifically closest to cranial nerve 6. So if we have an expanding internal carotid artery, what do you think is going to happen first? You're going to get cranial nerve 6 compression first, right? So once cranial 6 compression is out, the first thing you're going to see is problems with the lateral rectus, right? The lateral rectus, you're not able to abduct your eye, right? Because LR6, right? That's the lateral rectus muscle, is done by cranial nerve 6. Well, since cranial nerve 6 is right next to the internal carotid artery, any aneurysm or bulging of that artery is first going to hit cranial nerve 6. And then later on, you're going to get issues of cranial nerve 3, 4, V1, and V2. Okay, now I hope that makes logical sense for everyone, because the first thing hit is going to be cranial nerve 6 because it's just closest in proximity to the internal carotid when you have an internal carotid expanding aneurysm. And then the rest of them will follow as it continues to expand. So that's essentially all you really need to know about our cavernous sinus syndrome. All right, moving on to intranuclear ophthalmoplegia, or INO. Okay, INO, I'm going to give you 4 things. Okay, all you need to know are these 4 things, and you're going to get every INO question. It's very straightforward. Okay, first off, you have failure to adduct the ipsilateral eye. So failure to adduct the ipsilateral eye, adduct. Number 2, you get nystagmus of the opposing eye. Okay, nystagmus of the contralateral eye. You have MLF damage, and you have convergence and pupillary reflexes are normal. All right, so those are the 4 key things I want you to take away from INO. It's going to be failure to adduct the eye, the ipsilateral eye, adduct the ipsilateral eye. You get nystagmus of the other eye, okay? And then you have MLF damage, but convergence and pupillary reflex are normal. So let's just take a look at an example. So let's say we have right MLF lesion, okay? A lesion on the right MLF. If you are asked to take a look at the right, you're fine, okay? Both eyes are able to gaze off to the right. But when asked to look to the left, you have a failure of that eye, specifically the failure of the ipsilateral eye to adduct. So you cannot adduct your right eye, okay? So once again, you're asked, you have a right MLF lesion. You're asked to gaze to the right. Everything is normal, okay? Because the right eye is not adducting, it's abducting when looking to the right, okay? Now, you're asked to left gaze with the right MLF lesion. Well, now your right eye, the ipsilateral eye, needs to be adducted, but it can't. So that is your first sign. And what happens is that the other eye, the contralateral eye, Since it goes left and the other eye doesn't go left, it's going to realize, your brain's going to realize, and it's going to cause nystagmus, which pulls it back to the center. Okay? But convergence and pupillary reflexes are normal. That's what you need to know about this, okay? That's all you need to know about INO. If you can understand that you have a right MLF lesion and they ask you to adduct your right eye, you can't do it. And it leads to nystagmus of the opposing eye. And it's all because of MLF damage. Very easy, very straightforward. So let me ask you this. What happens if you have left MLF damage? Okay, if you have left MLF damage, you can look to the left. Everything is normal. You can look to the left. But whenever you try looking to the right, you can't adduct the left eye, right? You can't adduct that ipsilateral eye. But your right eye is able to move out. So then your right eye is like, whoa, the other eye didn't do anything. So nystagmus kicks in and it shoots it back to the center. Okay, very easy, very straightforward. Remember those 4 key principles. 1, it's due to MLF damage. 2, it causes a failure to adduct the ipsilateral eye. 3, it causes nystagmus of the opposing eye. And 4, convergence and pupillary reflexes stay normal. That's all.